In the summer of 2013, I had the opportunity to be a part of an internship program that granted minority college students exposure to health professions that lack diversity. This internship was a great experience since I had the pleasure of shadowing and learning from great clinicians that looked like me. Not only that, but we related to one another on a different level since we shared similar backgrounds and similar upbringings. This opportunity was truly inspiring because those physical therapists helped me realize that with diligence and determination, obtaining a doctorate degree in physical therapy was not unattainable. From there, I learned that building relationships and connections with my patients was crucial to obtaining better outcomes and a successful recovery after an injury, a recent surgery, or someone suffering from a neurological condition. I especially found this to be true when I treated patients that were from minority groups or people of color. Often they would say to me and thank me that they were happy to see a clinician that looked like them. Today, I want to discuss how a lack of diversity within certain healthcare professions is a health disparity, affecting people of color, people living in rural areas, and low income populations. But before I get into that, I want to introduce myself. My name is Dr. Kiana Howard, and I am a licensed physical therapist. I primarily practice in outpatient orthopedics, where I treat various diagnoses from musculoskeletal injuries, neurological conditions, and people that have undergone surgery. Since I've been practicing, I treat a wide variety of people from different ages, races, religions, people living in rural areas, or people from different socioeconomic statuses. Thankfully, I've been told by my minority patients how they appreciate me because they feel that their health concerns are being properly addressed. It's mostly known and trending that racial minority populations are at a higher rate for contracting chronic health conditions than their white counterparts. These conditions may include high blood pressure, diabetes, and cardiovascular diseases. Because there is such a wide difference between whites and non-whites likely to contract a chronic health condition, this is categorized as a health disparity. A health disparity is basically health differences between different groups of people. Some differences may include how many people contract the disease, the severity of the disease, how many people die from it, and how many people actually have proper access to healthcare to get screened for these diseases. Others may say health disparities are linked with different factors, such as social factors, economics, and environmental factors. Unfortunately, minority groups are more likely to have suboptimal care and higher rates of poor health outcomes than whites in some disease cases. So, could the lack of diversity in certain healthcare professions also be linked to health disparities? Let us turn our focus to the demographics and look at how we are actually being represented in certain healthcare professions. Pictured here is a graph of the United States population. A larger portion is comprised of white Americans at 76.3%, followed by Hispanic Latino at 18.5 and Black Americans at 13.4. The next image highlights physician populations by race. Similar to the US population graph, white Americans still make up a large portion of the medical doctors. However, all minority groups, except people that identify as Asian, are underrepresented in this profession. Now let's take a look at the physical therapy profession. As noted in the previous graph, white Americans still maintain a large portion of the physical therapy population. And all minority groups, except those that identify as Asian, are underrepresented in physical therapy. So how do we fix this issue? How do we improve the representation of racial ethnic minorities in healthcare? Primarily, there must be a pipeline system or some type of strategy in place to ensure that disadvantaged and underrepresented groups are represented. A lot of reasoning behind the lack of diversity in healthcare is due to the lack of exposure of different healthcare professions to minority students. For me, I was exposed to physical therapy in latter high school only because I had an ankle injury from running track. But what about those students who are not student athletes? Those students whose families may not have enough healthcare coverage to pay for a physical therapy session. How will those students know about the career or any other healthcare career that is underrepresented? This pipeline model has many levels, beginning from early childhood all the way to the medical professional. Getting kids exposed to different healthcare professions before college is important as they think about what they want to do for a living. The next level is the undergrad experience, which is vital for shadowing, volunteering, and getting exposure into the profession before applying to graduate school. Thereafter is the graduate admission process, which is key to having people on these review boards advocate for people of color to be accepted into these programs. Finally, licensure preparation is also important. This is important to ensure these students successfully pass their examination and be licensed medical professionals. An example of a successful pipeline is based on a study done at the Ohio State University School of Medicine and the University of California post-baccalaureate programs. These programs aim to help promising college graduates from disadvantaged and underrepresented backgrounds get into and succeed in medical school. From these efforts, researchers have found that the post-baccalaureate graduates were more likely than non-post-baccalaureate graduates to practice medicine in high poverty communities, high Latino, and Black communities. Nonetheless, research has shown time and time again that patients from minority groups that are served by healthcare providers that look like them have better outcomes. In another example, a study performed in Oakland, California, randomly assigned Black men to Black and non-Black doctors to examine the demand of preventative care. From this, they found that Black males assigned to Black doctors increased their demand for preventative care services. These services include things like getting the flu shot, monitoring their blood pressure, monitoring their blood sugar, and monitoring their overall health. From the same study, researchers also predicted a 19% drop in the Black-white male cardiovascular mortality gap, an 8% drop in the Black-white male life expectancy gap. Ultimately, increased racial minority representation in healthcare is crucial because diversity is associated with positive health outcomes. These outcomes would include things like increased access to healthcare for minorities, improved patient-provider communication, improved patient satisfaction, and lower morbidity and mortality rates among minority groups. The lack of diversity in healthcare is a health disparity for racial minorities and disadvantaged groups. Many healthcare organizations and professional schools are addressing these issues, but we still have a long way to go when it comes to diversifying the system. Hopefully, this talk can start a conversation and give you guys some insight on how we need to change and increase the need of minority health professionals, not only to reflect the people we serve, but to positively change the trajectory of how we treat patients and meet the continuing needs of the overall population. Thank you.
I am Rhonda White. I did not introduce myself. I am the clinical coordinator and assistant professor at Prairie State College in the new physical therapist assistant program. I welcome each and every one of you to this village of wonderful ladies that will speak tonight in regard to health disparities. I'm going to go ahead and introduce briefly the panelists. You should see everyone that is on your screen. Oh, well, wait a minute. There we go. Everyone is on your screen or coming in. They'll be on your screen shortly. So I just want to briefly introduce them. Again, you can look more in detail to their bios on the website that was created for this evening. So Dr. Chandrea Boyd works for a large hospital system in Illinois and in the Wisconsin area. She was born here in the Chicago area, and she did not start off as a physical therapist or wanting to be a physical therapist. She actually shifted gears and now has her doctorate degree. She received that from Nova Southeastern University in South Florida, and now she is practicing primarily in outpatient orthopedics. So let's welcome Dr. Chandrea Boyd. We want you all to know Dr. Dawn S. Brown. She is also a physical therapist. She is a clinical assistant professor and director of clinical education at Northern Illinois University's DPT program. She has 21 years of experience, and she is currently working on, she has a whole lot of degrees. She's currently working on her doctorate degree. She's getting an EED. All right, welcome to the stage, Miss Dr. Dawn Brown. Then we have Professor Monique Campbell, who is one of our very own at Prairie State College. She is a professor in our surgical technologist program. She has been a surgical tech for 13 years. She most recently received her bachelor's degree from Governor State University. Let's welcome Professor Monique Campbell. All right. Then we have Dr. Danielle Coleman. She is also one of our own at Prairie State College. She grew up on the south side of Chicago. She has a whole bunch of credentials behind her name, but Dr. Coleman is currently the director of our nursing program, and she particularly enjoys speaking to learners and ranging from K through 12 to adult learners. Let's welcome Dr. Coleman to the stage. Dr. Jackson is a physical therapist, a health advocate, and a citizen scientist, and a lifelong learner. She received her physical therapy degree from the University of Georgia, and she is the founder of the Center for Food Equity and Medicine. Let's welcome Ann Jackson as she's coming to the stage. Ms. Raynetta Stansfield is a MHA educated healthcare executive and consultant with extensive skills and experience across different healthcare sectors. With progressive and exposure to national and international healthcare compliance and organizations, she designs and executes successful strategies to enhance the quality and develop brands. Welcome Ms. Raynetta Stansfield to the stage. Dr. Sharice Thompson is a general dentist and educator. Dr. Thompson practices general dentistry in the North Beverly, Chicago area, and she is an assistant professor at Malcolm X College in the dental hygiene program. Welcome, Dr. Thompson. We have Professor Danita Williams. She's a first generation graduate from college, and she obtained an ADN in 1985, a Bachelor of Art in 2000. She is also an ordained minister, and she is a professor in our nursing and our certified nursing assistant program. Let's welcome Professor Williams to the stage. All right, yes, all right. So your question, Dr. Jackson, is this: what is health inequity, and what is the origin of inequity in healthcare for African Americans? And then lastly, how do we help our colleagues understand the importance of cultural competence on this subject?
Well, good evening, everyone. And thanks for giving me the first question. I will like to start with the definition. Health inequities are unjust differences in health between persons of different social groups and can be linked to forms of disadvantages such as poverty, discrimination, and lack of access to services and goods. I think that what we're seeing more and more in our quick sound bites in 2022 is health inequity is really associated with race. And it's not. It's really associated with a much larger framework of social determinants of health. These plaguing issues have been with African Americans prior to coming onto this continent. We have seen evidence of these types of discriminatory practices, even existing in our ancestral homes. And as long as there are ways for people to separate one another, and that's why I bring up the issue of class and poverty and discrimination, because as long as we have differentials of who we are and where we're stationed in life, these inequities exist. So they have been with us for time immortal. What we see now among African or Americans of African descent that are called ADOSs, Americans of American descent of slaves, is that these inequities are following us from the womb to the tomb. And these inequities are impacting our ability to live the longevity that we see in our counterparts who are not of the same ethnic origin. But it is not just because we're Black, it is because we are experiencing these other social determinants of health. So when we think about this issue of health and equity and how it relates to students and cultural competencies, we must elevate this question to a question of social justice. And so when we speak to our colleagues who sometimes feel very defensive, or we ruffle their feathers when we begin to talk about this issue of health and equity, perhaps we really need to take a step back and think about it and talk to them in terms of social justice, and that these inequities impact what we experience all across every strata in our country. So social inequities, health inequities for one, result in diminished capacity and quality of life for all. And that impacts this idea of cultural competency, because when we look at it in terms of the common good, then it gives us a space to start a conversation.
I feel like we can end our conversation right there. That's enough to chew on, right? So, I mean, we know that in 2022, we are involved in so much trauma just as a people. And I'm not talking about Black people. I think Dr. Jackson made that very clear, that it's not just about us. We are in a traumatic situation, period. But then you couple all of these other entities on top of that, and you've got this disparity that has been, it's busted wide open, right? It is so evident right now when we're talking about COVID and when we're talking about so many other things. So I love that you captured that differently, that we're not just talking about one thing, we're talking about many entities. As I was preparing for this, I started looking at videos, and I mean, can you go down a rabbit hole about videos and information that's out there? And I think that it's great for us to start a conversation, but just like Dr. Jackson, you talked about when we first started this, where are we going after? So the hope is that we shed light as a group on what health disparities are, but then secondly, we hope that we come behind you and spark some energy for change. Because like I mentioned on the radio program that I did on Monday, it's really about us all doing our own part, right? So if we all can do a little bit to make the difference, I think we can get there much faster. Anybody else? Okay. All right, Dr. Boer, here's your question. You're up. Share some common triggers that African-American patients wrestle with when they attempt to receive healthcare services in clinics and institutions located in their own communities. And what ways can we as providers and administrators help to eliminate those triggers?
All right, that's a big, giant question. So I have a lot to say, but luckily some of this has been touched upon. So good evening, everybody. We all know about triggers and microaggressions. These can come from leaders, peers, anyone. And triggers can be anything that reminds you of individual experiences or systemic racism. There's also a term called racial trauma. So as we just talked about trauma, RBTS, race-based traumatic stress. And this refers to the mental and emotional injury caused by encounters with racial bias and ethnic discrimination, racism, and hate crimes. And these experiences actually cause similar symptoms such as PTSD. So they can look like depression, anger, recurrent thoughts of the event, and even manifest as physical symptoms such as headaches, chest pains, insomnia, hypervigilance, which is constantly assessing possible threats around you. So you're always looking out for what's wrong and what's going on. And low self-esteem as well as mentally distancing yourself from the traumatic event. Triggers and microaggressions can look like anything, such as like all white professors, classmates, coworkers, and leaders, being graded differently or ousted from study groups or clinical rotations, being told you're smart for being in your circumstances or you're articulate for being a Black person, right? Maybe your opinions were devalued. We're going to get that throughout our lives. You may be seen as aggressive, angry, or difficult to work with, but your white counterparts are able to express themselves without consequences. Getting hugely reprimanded for small infractions when others don't see that same energy for larger infractions or same infractions. You having to perform 10 times better just to be told that you're still not good enough. Assuming that you're the assistant. How many of us have walked into the place and, we're not assumed to be the doctor, or we're not assumed to be the head person in charge or the one leading the exam. One of the more recent things were Black Lives Matter versus the All Lives Matter versus the Blue Lives Matter argument. All right. So in the clinic, data does show that minorities experience a higher rate of illness and death across a wide range of conditions such as diabetes, obesity, asthma, heart disease, and our life expectancy is about 4 years lower on average. How does the facility and the equipment look where you're working or at the place that you go in? Are funds being utilized there and put in the right places? There's a notion out there that people of color have higher pain tolerance and are believed when they're discussing their pain and other ailments, so that affects care. The disparities with birth rates is a big issue. It's always been a big issue, but a lot of us don't know the numbers. Per 100,000 live births for Black women, the mortality is 41.7 versus 13.4 for white women. But the data shows that Black patients tend to opt for more preventative care, and the mortality rates drop for newborns sharply when they're seen by a Black physician. How is the staffing in the facility that you go into? Is it inadequate? Do you see overworked and stressed employees because of that? We even can talk about insurance, right? Lower grade insurances and the biases that may come with that, even though they don't know why the person has that type of insurance. But they've also seen that two people can have Medicare, a Black person and a white person, but the Black person will be treated differently and with less options than the white person with the same insurance. And there can also be gaps in education and language barriers, right? If we are not educated and we don't understand what's being told to us, then we can feel intimidated and we don't want to go get the care because it may make us feel stupid. So how can we help? How can those of us that are clinicians help? Think about, who are you here for? Be patient. Put yourself in their shoes. Think about your own family and how would you treat them and want them to be treated. Remember that our people have been traumatized. So that attitude that they may display at 8 a.m. may have come a long way since 5 a.m. We don't know what people woke up to this morning or got awakened to. I've had instances where patients found out that they had cancer, but they were very short to the staff and myself initially, and they weren't trying to be rude, but they opened up and started crying and just told me what was going on. So you never know. Let our patients know that they are seen and heard. Just the familiarity with seeing you as a person of color goes a long way. So always remember that. You know the nods that we give each other when we see each other, especially in higher places. Recognize that our people have obstacles and struggles. So if they're being late to appointments or they're missing their appointments, you have to figure out, are they showing total disregard, or are they really trying and they just have a lot of things to struggle and get through? And maybe you can help them or alter their appointment times and so forth. Explain to them what's going on with their body without using medical jargon. You want to keep it simple. And because a lot of times you're going to be the first medical professional that's explaining what's really going on with their body. I've had patients cry just because of that. Okay. Help them navigate the system. Remember, insurance in the United States and healthcare in the United States is not a friendly, user-friendly system. So if just by giving them the next step or the next two steps that they have to do, could help a lot. You want to teach our people primary care physician behavior versus ER behavior. We got to start going to see our primary physicians and getting out of those ERs. Teach self-love and confidence. It's okay to ask for a second opinion. It's okay to speak up and it's okay to ask questions. It's okay to take care of yourself. We spend a lot of times running ourselves into the ground to take care of other people. Okay. You will get, what motivates you? You will get frustrated. You will be challenged, but our people need us. Everybody needs us. So you have to remember why you're here. Know that they need to know what they need to feel that they know we know what we're doing. Okay. So they also need to feel that we love what we do. So it's okay to speak your AAVE, which is African American Vernacular English. We know we code switch, but you want to make sure you also do it professionally because they actually love it. They actually want you to talk to them, not at them, but they also want you to be professional about it and know what you're talking about. Okay, so the more people that we can get to trust in the healthcare system, the more lives that we can save. You can help them find minority physicians that they feel more comfortable with and that they trust. And also ask for feedback from your patients about the physicians that they see in the offices, because they're going to ask you about referrals. So though you don't want to talk down about anybody, you may want to say, oh, I get a lot of good feedback. This physician has great bedside manner, but you might want to be a little patient with their front desk and so forth. Okay. So to wrap it up, we all have triggers. As healthcare professionals, let's work together and try to decrease these triggers so that we can improve on the health of our people. Their lives and their family lives and our future all depend on it. Okay, that's it. Unmute yourself, Ms. Ron.
Right. I'm sitting here, I'm wowing myself. So I should be wowing you. Thank you so much for your response. I appreciate that. That evoked so many emotions in me, because let me tell you what I think initially, and the panel can maybe speak to this as well. I think that we as African-American healthcare providers have to be given permission to do that, because of the fact that there's still a very big part of me that knows there is a game that I have to play. There is a leveling field that I have to deal with. I mean, I'm sure that the ladies on the board can attest to this. I was the only African-American student in my class of 32 coming out of physical therapy school, right? And so there is just this umbrella, there's this whatever. I come from this generation that I have to represent my people and my culture. So there's a weighing that you have to do, and it's very heavy. And I think as healthcare professionals, we have to be given permission to do that, to be in those spaces and to make it a safe place for our patients, but also make it a safe place for our counterparts. I want my counterparts to ask me. I don't know everything. I don't want them to assume that I know everything about every Black person. And I don't want us to get into this, but I want some people to be vulnerable about some things, as I am vulnerable about. We are forced as African Americans to learn about other cultures, right? Nobody is forced necessarily to learn about us. And so we have to take that into consideration. So I appreciate your words, because I feel like we need to give each other permission to have these conversations. And sometimes they're tough. And guess what? That's okay. That's the only way change comes, if we have the tough conversations, if we are intelligent enough to have them and to keep moving on. All right, anybody? All right, Dr. Thompson, you are up. What are the common biases in the admissions process of allied health programs, and what can be done to help improve the ratio of African Americans enrolled in allied health programs, especially at predominantly Black institutions?
Well, good evening, everyone. Thank you, Ms. Rhonda White. That is a very loaded question, and a question that is fluid, because it is still being worked upon as we speak when we talk about admissions. But when I decided to take on this question and do my homework on it, it's something that is kind of dear and near to my heart, because I do work with students in the dental hygiene program that come into our program, and I do sit on our admissions committee. And it is a loaded question, because when we go back through time and everything everyone else has said and talk about African Americans coming into healthcare, we know when we look at our numbers, and the TED Talk looked at it, she looked at it so closely and looked at how wonderful, looking at the whole point of these numbers. So when we talk about diversity, how do we increase the diversity of healthcare workers in our schools, in our institutions? How do we bring that about? Well, it's a strategy. And that strategy is how do we reduce the racial and ethnic health disparities? It goes back to what Dr. Jackson said. We talk about disparities, but we see it also in the admission process, or what is represented in our classrooms, or us ourselves. If we all just sit back and think about our day in the classroom. You said it, Ms. White, Professor White, you were the only one in your class. What year was that? When we go back to the 80s, I came out in 1995, hard to believe, but I did. 95, at that time, there were 70 students sitting in my dental class. There were 3 of us that were African American, and 1 was from Jamaica. So then I moved on and transitioned to another dental school because our school closed. 1 African American sitting in that class, 1 male. So when we ask ourselves, what is going on and how do we address the disparities in the admission process? When we look at and I'm talking from the 90s to where we are right now, we've seen a little shift in the numbers, but not a great number. If we go back to that TED talk, we've done some work, but not enough work. So in my research and going through some of the evidence-based literature out there about addressing it, there was one article out there in the Institute of Medicine report that talks about uh, the the equity, or what we need to do, or what it serves as a blueprint for addressing these inequities. And I just want to just bring some 3 points. I always talk in threes in the classroom because 3 points help people remember. So here are the 3 points we want to think about. How can we increase the proportion of underrepresented minorities in healthcare through the institutions? One, it was mentioned in the TED talk, which is true. We have to think about a pipeline. Where does this pipeline begin? And she mentioned it, early childhood, going into the classroom from kindergarten up until 8th grade. Our STEAM and STEM programs can act as a conduit as well as teaching our young men and women about these healthcare careers. Professor White did one yesterday. She did a STEAM yesterday with one of the science programs where young girls and young ladies and young men are learning about our healthcare. What inspired me when I met these young ladies is all these women you see on this panel today. When we met, I sat here and went, wow, what an honor to be among us. First of all, I'm proud that all of us are on this panel discussion today. But what I want to hit home in that pipeline is and one of you mentioned, and I said that we can't just keep talking about African Americans or Blacks in healthcare with nurses and doctors. And many of our children, they say, I want to be a nurse, I want to be a doctor. They don't think about, look at what's on this panel discussion. We have physical therapy, we have occupational therapy, we have PhDs, we have nurses, we have dental hygienists, we have dentists, we have radiologists, we have phlebotomists, we have medical technicians. We have so many areas of healthcare that our young young men and women have no idea of. And Dr. Jackson mentioned it. Until you come into a experience of it, physical therapy was my first introduction with my father being rehab. I said I wanted to be a physical therapist before I wanted to be a dentist. So until you have an experience of these professions, some of our children have no idea that it exists. Many children, I find out, don't even know that dental hygiene, dental assisting, and dentists exist out there. They think about just nursing. So the pipeline is important. We have to open up these pipelines with workshops, having summer programs starting in our high schools. Look at our park districts. Use these grants that come into our institutions to think out of the box of how we're going to do programming. Come up with panel discussions like this and summits that are going to inspire our young children. And then we need to look at our admission process. When we have the pipeline and introduce them into coming into these spaces, what are we doing at the institutional level? What are we doing to look at that? So I did my homework, and there is an article that talks about holistic, looking at our admissions processes as holistic. Well, what does that mean? What it means is, how do we go in and not look at just the academics of a student? We need to goal is to recruit racially, ethnicity, and culturally that looks like our people that we serve. And how do we do this? We look for our students to come into our programs by looking at what they can come in with besides just the academics. We want to look at their background, their diverse first-time generation graduate, socioeconomics. What communities or geographic areas do they come from? What backgrounds do they come in with when they come into these programs? Then just, did you pass the test? Do you have a good GPA? And what's your desires to be in this healthcare career? The third point, not only looking at our admissions process or looking at a holistic admission practice, we want to partner in our communities, and we want to look at those workforce partners, the people people in our communities who say, hey, this would be a perfect opportunity to sponsor a student. This would be a great person that can come into your program. We can look at organizations that can help us with this underrepresentation of students. So I just want to end with, I will put it in the chat, but there was a wonderful article that I read, and I just want to read this. To address the need for diverse healthcare workforce, university leaders are employing holistic admission practices. The term holistic review is often used interchangeably with holistic admissions, and it refers to an admission strategy which considers the applicant's unique experience and attributes alongside traditional academic achievements. So, not only looking at those standard tests or how they did, but we want to look at the well-rounded process to bring them into our programs. And I believe those of us on this panel and those of you who are listening from other institutions, we also must employ diverse faculty. It is hard to go into a program like a dental hygiene program, a dental program, an OT, a PT, a radiology program, all of these programs, and you don't see people who look like you. When you see one faculty member of color, that is not a great representation of your program when we know our program should be a diverse program. So we have to do better at bringing in more diversity in our programs with our faculty and our administration. And when our students can see people of color, that can be also a support system. And then I like to end with just this information with the statistics from the 2021 U.S. Bureau of Labor that says racial and ethnic minorities comprise 40% of our population. Let's look at this number. If they comprise 40% of our population, when we talk about the labor workforce and healthcare, 18.5 are our Hispanic and Latino, 13.4 is our African Americans, 5.0 is our Asian, and of course, the statistics didn't bring into it our dental hygiene was not represented or dentistry. So we have to start these conversations about not only the pipeline, but once we get our students into these institutions, how we can support them. And lastly, I'd like to say, when we talk about what is the driving action for us, the driving action should be recruitment, admissions that has a holistic review. And lastly, once we get them in, as I was told when I was arriving on my campus for dentistry, we'll let you in, but we don't got to let you out. So that means we have to have student support services. We have to have wraparound services for our students once they get in because they're dealing with so many different disparities. So thank you again for that question. There's a lot to unpack. And I'll be happy to put that information in the chat from that study. There is a lot of studying going on university campuses about this holistic view of applicants. And I ask us all to partner with each other and challenge our institutions and our deans and our admissions. Let's make changes. We can't keep doing it the same way, academics only. We have to look at these other holistic concepts to bringing in a variety of ethnicities that represent what we serve in our community and what we see in our schools and what we see in the population. Thank you.
All right. School is in session, ladies and gentlemen. School is in session. I hope you are taking some good notes. I am learning so much, and I've been around them already, and I'm still getting some more. So we're going to keep going. I think this is a nice flow. Now we're talking about what's going on in our program. So now we've kind of landed. We talked about patients, what health inequity is. Now we talked about the admissions process. And now Dr. Brown is going to talk to us a little bit about how students feel once they're in programs. So your question, ma'am, is how can we as healthcare providers and educators improve the sense of belonging that is felt among African American students in the classroom and during their clinical experiences?
Gotcha. So thank you for that question, and thank you all for attending our panel discussion. So before I dive deeper into, the sense of belonging, I think the first thing that we have to do is understand the why. Why is sense of belonging important before we can really dive into what it is and then how do we achieve it? When we think about sense of belonging or belongingness, it's paramount to the mental, the physical, the emotional health of all of our students and even our faculty, because it gives you a sense of purpose. It gives you a sense of meaning. We know that research has shown that when students have a sense of belonging, that they have better outcomes with regards to what happens in the classroom. They have better outcomes with regards to what happens on their clinical experiences. And then research has also showed that there are adverse effects of the absence of belongingness or the absence of the sense of belonging, because it can sabotage a student's ability to fully participate in the classroom as well as in the clinic. And this can compromise their overall academic achievement. So then we look at the what. What exactly is sense of belonging or belongingness, as the word is used in most of the research? Well, it's a quality or a state of being, an important part of something where you have this emotional need to be part of a group, this emotional need to be connected to something. And so when we think about healthcare, and when we think about all students, especially students that are marginalized or minoritized, and since we're talking about the Black experience, well, how do we do this? We have to start this in the classroom before we can even look at what the belongingness looks like in the clinical setting. This has to be modeled there first. And so we, on this panel, because we've talked several times before now, we have all had experiences where we were the only, whether we were the only in our classroom, in our respective fields, whether we were the only in clinical practice, or even been the only in our institutions for those of us that are faculty. And so in order for us to facilitate that sense of belonging in our new generation of students, we have to make sure that in the classroom, all the faculty, all the professors and the teachers prioritize having a high quality relationship with their students. You have to get to know who your student is, what are the social, cultural backgrounds that define them, that make them who they are, and then respect that and take a vested interest in your students. Because if you don't, then you're basically just going through the motions and teaching them without realizing who is on the receiving end of your teaching. Create a space in the academic environment to support your students, to show them that you have that compassion and that you have that caring for them as a person, and then toward them in learning the material within your respective profession. Create a space that's diverse. We have been talking about earlier that representation matters. And so if we talk about the classroom as being the starting point to facilitate the sense of belonging, well, we need to have students being around other students that look like them. You can't just have one Black student in your classroom and everyone else around them is white. You can't have just one faculty who's Black or of color and there are no other faculty, let alone have a student who's Black in your classroom and all the faculty are white and all the students are white. How do you think that student feels? What do you think that's going to do to their sense of belonging and even to their confidence? Oftentimes we talk about a student having a lack of confidence, especially if they're a minority student, because they don't know the material. Has anyone ever thought that that lack of confidence is because they're afraid to speak up because no one else shares their perspective or even includes them when it comes time for group projects or team assignments? And so that's very important to consider. When you're faculty and you're in the classroom, be equitable in how you communicate with your students of color. Be equitable in how you assess them and how you evaluate them. That's how you start to facilitate that sense of belonging. Faculty members and professors have to model inclusive behaviors and make sure that they expect the same thing from the rest of their students in order to, again, foster that sense of belonging. As a physical therapist, as a professor and a clinician, having been practicing for over 22 years, I take, a vested interest in the belongingness because I felt, as an outsider when I was in school, when I was in clinical practice, and even as a professor, because I don't see representation. What I'm doing now in physical therapy with my research team, we have just concluded one of our studies on validating a measure to look at sense of belonging within physical therapy programs in the clinic. And so we recently validated a belongingness scale clinical placement experience It was already validated in nursing, it was validated in medicine, but it hasn't been validated in physical therapy or other healthcare professions. And so we just had it validated. We're writing up our manuscript now because we feel that this is an important starting point so people can take our survey, use it in the classroom, use it in the clinic, and figure out how do we increase that sense of belonging? What are we doing wrong and what do we need to do right so students feel like they should be included? Some of the sample questions from our validated survey include, I feel understood by my colleagues. Another question is, there are people that I work with on my clinical experience who share my values. I feel discriminated against on my clinical experiences, or on my clinical experience, I feel like an outsider. So there are 34 questions in our validated scale. It's on a 5-point Likert scale. And looking at that data, we're able to make some inferences as to what makes a person or a student feel like they don't belong, and then hopefully using the scale to generate strategies so that we can be more inclusive and really make sure that our classroom environment and our clinical environment is warm and inviting to all students, but especially our students of color, especially our Black students.
I don't want to run the panel anymore. I want to sit back and listen. I just have to take a few minutes every time you all speak because it's evoking so many emotions. Do you get a sense of students just have to, we are tightly wound through our whole experience. We're trying to hold it together. We're trying to impress. And I'm talking about any person. You know how stressful it is to be a student. And then you put these things on top of that. It just makes that even a much more intense problem or issue. So we're going to keep on moving and talk a little bit now about retention. So we've given you some examples. Dr. Brown gave you so many platforms as to how you can run your classroom differently and look at it differently. Now we're going to move into Dr. Coleman's question, which is, why is the retention rate in allied health careers so low among African-American students? And what can be done to expose the problem and reveal the problem to others?
Okay, thank you very much. Thank you very much. I feel like you, Rhonda, I don't think I have much more to add to this conversation because they've stepped all over my notes, but it's okay. I got something to add. So the first thing, actually, I want to start with a tagline that's on my email, and it says, students do not seek to be retained. They seek to persist. And this is by Tinto from 2016. And that is probably the best thing that I could add to this conversation is, we're so busy trying to run behind the situation instead of trying to figure out how to not let it happen in the first place, right? And as a nurse, I've heard, I don't take it personally, but I've heard in this conversation, everybody wants to be a nurse. No, they don't. We have had such a need for nurses that we could never catch up. Like, if you look at the numbers, we have been so behind the 8 ball, it's ridiculous. And, so everybody thinks that nursing and doctors, that's where everybody wants to be because they know about it, but that's not the truth. We really need the help where we've got nurses who are retiring, they're burnt out, they're exhausted. If you talk to a nurse on the floor today, she would be like, I've got far too many patients to take care of, far too many things to manage, and I want to get these people home safely, but it's almost impossible that I'm gonna see everything or meet every need because I just got too much being dumped on me. And that's today, not even with the fact that we have a pandemic on top of it. So, the numbers, everybody thinks nursing. Everybody knows about a nurse, but they don't want to be a nurse. So, one of the things that I found when I was doing my research, I did a lot of research just in general about why we couldn't keep nursing students in the seats, why we were having such a problem. A lot of people don't realize we admit, let's just say 100 students. And by the time they get to the end of their first year, we've lost 40 to 50% of those students, 40 to 50%. So I bring in 100 students today, and a year from now, 50 of them are gone. Why? If everybody wants to be a nurse, Why are these people, why are we losing them? And we're losing them for a variety of reasons. We're not losing them. And I know this is not just nursing, because I've heard Rhonda talk about it. I've heard, dental hygiene talk about it. I've heard about other areas in allied health talk about it. So I know it's not just us. We just are kind of spotlighted, but why are we losing them? Well, a lot of times we're losing them because they just don't have the support. And you heard this kind of talked about before. So like, we're forecasted to grow faster than average. 7% is the nursing by 2029. So that's more than 221,000 jobs within the next few years, right? As of 2021, we have 4.2 million nurses, 4.2 million nurses in the United States. Now I'm about to break that down. 10.2% of them are African American or Hispanic. Let me make that clearer. That is 428,400 people out of 4.2 million are Black and brown faces. 428,400. So that's about the size of a place called Alameda County in California. Now we know how big California is, right? And this is just a small part of California. Alameda County, California, that's the size of that location. Is the entire population of African American and Hispanic nurses in the United States. So, okay, we need nurses, right? American Association of Colleges of Nursing in April of last year said BSN programs have 251,145 current students. This was last year, right? But they declined 66,274 qualified. I'm sorry. He barks at everything. I'm sorry. Okay. BSN programs. BSN programs have 251,145 current students in 2020, right? But they declined 66,274 qualified students. They declined students who are qualified, but we need people. That doesn't make sense, does it? No, it doesn't. Nursing faculty is expected to shrink by 25% by 2025. 25% nursing faculty. Now, if you've come to our school, we've got a great nursing faculty. It's 11 of us, and we're expected to decrease by 25%. That's impossible. We can't work like that. Reasons: retirement, burnout, and pay. Currently, there are 61,000 nursing instructors currently, and we're going to lose 25% of them by 2025, which sounds like a long way away, but let me see, this is 2022. 3 years. In 3 years, we're going to lose 25%. Recent AACN report found nursing schools could not accept over 75,000 qualified applicants for BSN and grad school due to inadequate faculty, clinical sites, classroom space, clinical preceptors, and budgets. Money. Okay. Money. Nursing students drop out. Why? Lack of resources to devote 100% of the time to the nursing studies. I just wrote a letter for a student today who's going to quit her job because she can't keep up with the coursework, and they don't understand why. She's only in an 8 credit hour class. That's not full time. Why do you have to quit your job? Let me make this clear. She has 8 credit hours, but she has classroom time of about 4 hours a week. She's got clinical time of about 6 hours a week, and she's got lab time of about 2 hours a week. And we tell them that when you are in our program, or any program, I'm sure, that you should commit 2 hours for every credit hour of study time. So that's 16 hours a week. Short of sleeping, eating a donut, and running out the door, where does she have time? Now, we don't want our students to live on the street with the squirrels, but we want them to be successful because they came into this program with a dream. They came in with the desire to be a nurse, probably because they don't make a lot of money where they're at. They need to get their family into a better situation, blah, 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 right? So how are they going to do that if I have to work full time? I've got my kids, that I've got childcare issues. I have maybe a 1974 hoopty that I'm hoping will get me to and from school, to and from clinical, to and from lab. You all are laughing, but you know it's true, right? And the fact that maybe I'm taking care of my elderly parents, plus I got my kids, so I'm in the sandwich position, and you just threw nursing school on top of all of that. right? So lack of resources, childcare, working outside of the home, being a caregiver. These are the reasons that students drop out. That's just the dropouts. That's not even the people who can't keep up. They're trying everything. Like I've seen students, and I know this is not supposed to be personal, but I've seen students who have put in everything. They have done everything they could. They've come to every supplemental instruction, which is our tutoring. They've come to every open lab. They have kicked their family out. They've divorced their husband, wife, whoever. They put their kids up for adopt. They've done everything, and they still fail the program. It's just too much, right? It's that one thing that falls off the wagon, then it's just like, I just can't do it. Okay, I'm not even gonna go down that road. Okay, common barriers for minority student success. Common barriers, lack of emotional and moral support. My sisters on the panel today have talked about the fact that if we are not supporting our students in the holistic manner that they're dealing with, they're not just dealing with school. Like as a nurse, I'm teaching them, you've got to deal with the mind, you've got to deal with the body, you've got to deal with the spirit. The person, you can't pull the head off the body. I don't care how you try, it's not gonna work, right? So if I don't want to be a psych nurse, I'm in the wrong place, because I'm gonna deal with a psych issue, whether I'm a med-surg nurse, an OB nurse, or whatever, right? On the flip side, if I'm an OB nurse, I'm still gonna deal with those psych issues. Or if I'm a psych nurse, I'm still gonna deal with the fact that you got COPD, you got CHF, you got diabetes, or sugar, as my grandmother liked to call it. I'm still gonna have to deal with the rest of you. So I can't pull the head off the body, and the rest of you is gonna have to come along with the ride. So the fact that we're not supporting the students emotionally and morally is a big problem. Feelings of isolation and loneliness. If I don't feel like I belong, I'm gonna slide out the door. It's just that simple. I'm not going to commit to the things you're asking me to commit to because of the fact that I don't feel like I belong here. And I remember being in this program, many moons ago, there was one African American instructor. One. I wasn't the only Black student, but I had only one Black teacher. And she was fighting the good fight for us. But it was a relationship that we had to do our part as well. But I didn't see myself in her. And okay, I'm gonna be real transparent here. I had to repeat my second semester of nursing school. And part of the reason why it was so hard to come back was I was like, they hate me. They don't want me here. They don't like me. All the things I hear my own students say now, but I didn't feel like I belonged. I didn't feel I was smart enough. I tried all the stuff. I didn't work. I'm gonna go be a dog walker, whatever. But it was the feeling of inclusion with my fellow repeating students or my fellow repeating colleagues that helped me get through that part. And that's why I make that information known to my students, because I know, especially with our Black and brown faces who are at the height of the ones that we lose every year, I make it very clear, look, repeaters unite. I know what you're going through. Come on back. We're going to get through this together. But they have to see that there is something beyond that failure. Okay, I'm going to get off that racism and discrimination, family support issues. I can't tell you how many times, just as a person in this position, we've heard, my family doesn't understand that I've got to study this much. I can't be the first wife. I can't be, first lady at my church like I used to be, or I can't go to my son's basketball game like I used to, or I can't support, my sister at her wedding. I remember missing birthdays, funerals, weddings. I took my notebook to my girlfriend's bachelorette party. I was in the corner with my notes. And it's like, baby, you look nice. Oh, you look so pretty. And you're going to be beautiful on your day. And there I was. And that was the only way I could be there, because she knew otherwise I'm not coming. I can't be there. Right. So family support issues. We've got to learn how to include the family in the decisions of the students, because it doesn't just affect the students. I'm not going to just stop cooking for me. I'm going to stop cooking for everybody. I'm not going to just let my part of the house go down the drain. The whole house going to look a mess. I'm not going to just stop going to my own stuff. I'm sorry, baby. I want to come to your play, but I can't because I got a test tomorrow, and mommy wants to pass, and mommy wants you to see her pass. Right? So we've got to help the families to understand that. One of the things, I know I'm kind of jumping around. I apologize, Rhonda. I got real excited all of a sudden. But one of the things that one of my students said that has made the most impact on me, she's a military wife. And she said it was understood when my husband was in the military, we were a military family. Everybody was in the military, kids, me, everybody. So when she went to nursing school, he made it real clear. We went to nursing school. He understood that they were a nursing school family and they supported her like she supported them. That stuck with me because I was like, that's the way it should be. But that's not how it is, especially in our Black and brown families. Maybe more in our brown families, but not in our Black families. We're not there yet, but we're getting there. Barriers to diversify, because my sisters talked about diversity. Barriers to diversity in nursing student success. Lack of financial support. I don't have the money to pay for this. I especially cannot quit my job of full time, and I got to work all these extra hours because I got to pay for this and that and the other. Plus, I still got to pay for staying in the house because I don't want to be outside with the squirrels. Insufficient academic advising. Our advising has to support them from the ground up before they even get to us. Program mentoring. I think that is a huge thing. I think it was Dr. Thompson that said, once we get, it's hard to get in, but we don't have to let you out. You're going to have to write that down for me because I need that on my wall because I'm going to be like, I don't have to let you go. I don't have to. That's not in my contract. I love that. Just being able to support them that way. Technical support. We found with this pandemic that everybody doesn't have the technical capabilities. We probably found it out on just this call alone that everybody doesn't have the technical capabilities to be able to manage an online space, right? Or just the use of a computer. We moved to computer testing at the beginning of this pandemic. You'd have thought we'd have took somebody's puppy out because they were just like, well, how come I can't have this? And why can't? And it was just like, it's just a test. It's just like the NCLEX. You're going to be okay. You're going to be okay. We're going to get through this together. And then professional socialization. I heard about you guys talking about professional socialization. And that is a huge thing, especially in allied health, because one of the things I found as I was researching for this was it's a lot of what hinders our students is what they see in practice. Like, nursing, unfortunately, has always had the saying, nurses eat their young. We become little baby nurses, and the most senior seasoned nurses just chew us up and spit us out, and then we quit after a year because we don't know why they did that. And I'm seeing a change, a shift in that, but you still see where, you don't know nothing because you came from wherever and that if we could just underroot the problem in practice. Like, our students go to clinical, they see this, they see how people are treated or how people are talked to, or if a doctor speaks to me a certain way, we got to have a conversation. We're not going to have this conversation in front of the patient. Or if a patient speaks to me a certain way, we've got to have a conversation. I can't say that I've never been dealt with in a way where I felt discriminated against. I absolutely have. I'm sure everybody on this panel has. But I remember one of the things that one of my friends who's on this call, you got to keep it professional. Sometimes that's hard because you want to come back with, oh no, you did not just say what I think you said. But we have to show our students who have a hard time separating personal from professional, that there is a way to handle these situations, because we still have some people in this industry who think a certain way and they will still act a certain way. And I don't have to respond to that in your way. So I think that's where I find with students why we are having such a hard time retaining them, because we're so busy chasing after the fact. We've really got to figure out a way to when we get them in, how do I keep you in? 40 to 50%. I promise you that hurts my heart every time I say it, but 40 to 50% of my little babies who come in with this little gleam in their eye that they are going to be nurses, and then I have to say goodbye to them before the end of their first year. And that is the hardest thing, because I know how it feels. And it's not always because they're not smart enough. They were smart enough to get into the program. We just got to figure out how to keep that smartness going and keep them in the program. But we've got to be transparent too, because I promise you, as soon as they hear that the director of the program she failed out of it's still, when they hear that, they're just like, wait, you failed out of this program and you that person? And it's like, yeah, it did not have to end with that. And so I always encourage them to come back and we do it together, and most of them make it. So that's the end of my little speech. Thank you for listening.
I really hope you all are getting something from this, because if you're not, I'm maybe you have your ear pods in or something, you're not listening. I'm not sure how to make you feel any differently, but this is a wealth of knowledge, so many nuggets. And I know that we're heading towards the end of our time. We still have a couple of questions, but what I wanted to remind you all of is that I just put the website link again in the chat. Please take advantage of looking at that website. You can look at the bios of each of our participants. You can contact them directly from that website. There are also some resources there's a resource page where you can continue to get some information about health disparities and health inequities in healthcare. And so I really want to encourage you. I want you all to stay. So I'm telling you now, I'm holding you in class a little bit longer. If you want the full effect of it, you've got to stay. So give us a few more minutes. We've got a couple more minutes to entertain. But again, I want to repeat this because people have been coming in the room at different times. If you are a student here and you want credit for being here, please fill out the survey, but include your name and your email at the bottom. That is important. I cannot get this information to your professors to let them know that you're here. So do that, and then also fill out the survey because we want to know what you feel about this presentation. All right, now let's roll on to Professor Danita Williams. Your question is, how do we as educators instill a sense of confidence and self-esteem in our African-American first-generation students in the classroom and in their clinical experiences?
Well, good evening, everyone, and I'm just excited to be here. I want to piggyback off of what Dr. Coleman says, because one of the things I say to my students is this. I said, I was that person that had to repeat, not only once, but twice, 5 years apart. Because the first time I went through nursing school, I was in an abusive relationship, husband throwing books out the window, and I dropped out. 5 years later, I went back, okay? And then when I went through the program, when I got to psych, not my forte, but I learned to work it, I had to repeat that class. And so now, fast forward, here I am. And I'm still that first generation person in my family to go to a college. Now I've had cousins and them come behind me, but I was the first. So it was a lot of pressure on me, okay, to go through. And so the first time I didn't make it through nursing school, my family said, okay, we get that. All right. But when I got back in, and I sailed through that first year, did pretty good. I get to second year and I didn't make it. I had talked to everybody in my family. My aunts and them called me. How come you didn't pass? What you do wrong? What you need? My grandfather said, well, you working? You don't need to work. I'm going to send you some money. You ain't got to go to work. You got all the books you need. My father bought me a cassette tape player, and I was using batteries with it. He found where you could get the one that you can plug in with the cord, bought the cord and the extension cord. So what are we talking about for first generations? Everything that we've been talking about. We need to support them. First generation people don't necessarily want a handout, which is based on one of the articles that I read. Just because I'm first generation, I don't want you to pity me. Teach me how to navigate the system. That's what I need you to do. Teach me how to navigate the system. Sometimes you're going to have to do that holistic. Say, you got this. Did you study? Did you do this? I expect great things from you. Okay. The same words that we want people to say to us when we're struggling with something. How are we struggling with this? I can't get this TV to work. The phone ain't working now. My cell phone acting up. And then drop 2 or 3 people. I'm calling my daughter, fix this for me. The same thing. That's what first generationers want. And a lot of times they're easy to pick up in your classroom, because those are the ones that are going to ask you a question and you're like, she should know that. Nope, she shouldn't. And then you just kind of start talking to them. You know, you get that general conversation going, that we're just talking about family and friends, not talking about school for that 10, 15 minutes. And they'll let you know, well, I'm the first person in my family to go to school. Mom and dad didn't go to school. Yeah. So that's when you pull them over for me. That's when I pull them over and I had that one-on-one conversation. Okay. So what are you doing? How are you studying? Well, I don't really know how to study. I said, okay. I said, are you open to me getting you a study partner? Yeah. I go find that person who I know is getting that A and I pull them over. I said, hey, how you doing? I said, can I ask you a question? And it just stay between you and I. Never give the person's name. I never violate FERPA. I never give the person's name. Will you be willing to let her call you to, one of my students call you to ask questions that's in the class? Yeah, Miss Williams, I'd be willing to do that. They'll do it. And when I cultivate a classroom that is sharing, inviting, teamwork makes the dream work, I have watched my students help the other students who can't get it. And I teach in the theory CNA. I teach in the lab. I do the lab portion and evaluate the skills for nursing. But the last class I had a student, she just didn't get it. And I went over it. I walked her through it. And so each of my students said, that's okay, Mrs. Williams, you go over there. We got her. Nope, you got to do it this way. Got to turn her this way. Got to hold the arm this way. You got to turn her this way. Got to wipe this way if you're doing pericare. Nope, do it again. You did it wrong. Come on, do it again. And by she did, they kept going through it. And when I talked to her, she wasn't the first person to go to school in her generation, in her family generation, but she had a learning disability and she was scared to go to school. So she stepped out and she was trying it. Okay. And even in the first generation people, the article that I pulled up for the first generation students, it says that they seek academic help. They will seek academic help, but the academic help has to come a certain way. Oh, you just do it A, B, C, D, E, F, G, and that's it. Now that's not going to work. And I can tell you it's not going to work from the person who went into a totally different academic field into seminary. And they're like, well, no, you can't write the paper like this. Well, why not? What's wrong with it? I spent 3 days writing this paper. What's wrong with it? Okay. And so what they had to learn, and us who were what we call returning students, the older students coming to seminary, they had worked 20 years. We didn't work 20 years. Now we're answering our call. Oh, we got to teach you a little differently. So this is the expectations. And so when I think about the framework for the first generation person, we have to give them the facts, but we also sometimes have to hold their hand, do a little hand holding. We got to do a little checking in on them, okay, to make sure that they're doing okay. And I get it that if you have 88 students, that's kind of hard. I do it in the lab. Okay, how y'all doing? We're doing good. Y'all gonna pass this test? Oh no, Miss Williams. Well, if you don't believe you're gonna pass the test and everybody done flunk, we don't need to give y'all a test. Miss Williams, why you say that? Don't say that. I said, okay, let me say that again. Who gonna pass this test? Okay, Miss Williams, I get 2 or 3 up. I said, she gonna pass. She gonna pass. You raise your hand, you ain't gonna pass. Okay. Did you study? Then I start asking the questions. Did you study? What's the test gonna be on? Okay, because I don't always get that second portion of the information. And I get that some of them are not first generations, but they're persons who were afraid to go, as Dr. Coleman said, but they stepped out and that's their dream. They want it. And so when they step out, I feel like it's my job as an instructor to give them that holistic part of it, that emotional support, even to the point that I've had students come behind the curtain in tears. Okay, why are we crying? Boyfriend just broke up with her on a text. She got it before she came in. Okay, I tell you what, you gonna take you 20 minutes and I'm gonna take 2 other students in front of you. Okay, Get yourself together. I said, I'll put your picture on eHarmony, baby. We'll find you a man tomorrow. You look good, girl. Okay? You look good, girl. It's not like me. I'm 62. I'm old. I can't find nobody. But we will find you somebody tomorrow. He'll be a good guy too. Okay? All right? But that's the emotional support that the first generationers need as well. I can do this. And even the first generationers that's coming in, they have worked 20 years and decided, I've always wanted to do this. So now I'm going to go back and try. Because I've gotten those students as well. And they were sitting, they said, Miss Williams, I don't know if I can do it. Yeah, you can. Why you don't think you could do it? Talk to me. Why can't you do this? You could do this. But what if I fail? So what? Delay is not denial. It's just delay. I failed. And failed twice. I failed twice. I failed, but I kept persevering. If you continue on, if you do everything, if you're learning the material, reciting the material, I give you plenty of stuff to practice with. Yes, I'll take a text from my students at 8 o'clock. And after 8 o'clock, I'm like, I'm done with you. Okay, I'll answer it tomorrow. I've had a student ring my phone at 5 a.m. and I forgot to cut it off. I said, what do you want? Miss Williams, you know, we had a test today and it started 6, and I was just nervous about it. I got a question. I'm not answering your question. You know this information. Go look it up in your book. Bye. And then I wouldn't let her in the test until I called her at 7 o'clock. Now, what's your question? You woke me up at 5 a.m. What's wrong with you, baby? My question is so-and-so. I'll say, did you look in the book? Find it in the book. Tell me what page it's on. And they can't. I said, so you know this. They just need to know that they got somebody that will help them. And yes, this is African American History Month. Yes, it is. I'm not going to tell you it's not. But sometimes with our counterparts, being Caucasian, Asian, Latina, we can find that person and that person as well as those persons who look like us. And that's the total inclusivity of it. And we must maintain that total inclusivity of it. And I just don't give it to my students who look like me. I give it to all of them. And in that, my first generation people come across all colors. Okay? They come across all colors, all ethnic backgrounds. I have had them. And they just I had one student just sitting in the class and she just shook. And the first day she was in the class, I didn't say nothing to her because they don't know me yet. But the second day we in the class, I said, come here, talk to me. What's wrong? Why are you sitting there shaking? I'm scared. You know, my dad and them, they worked hard to give me the money so I could get to class. Okay. I hear you. Okay. I don't know what mom and daddy did, but they worked hard. They saved the money to get her the class, to get her the books, to get her everything she needs. So let's make sure she passes it. Let's give her, and I tell my students, I'm going to do my part. I'm going to give you everything you need. I need you to do your part. Don't wait till the last minute to try to do everything. That's not going to work. Okay. I had one student, Miss Williams, my cousin wants me to come over to her party. I said, okay. She said, but our test is Friday. Not Friday, but Saturday is the party. It's Friday. I said, that's okay. I said, you're going to get a chance to study Friday? I said, yeah. When you walk into that party, set your alarm clock on your cell phone for 2 hours. You go in, you party hardy for 2 hours. Don't drink too much because you got to come back home and study. You come back home, you say, okay, I was here, holler back, and I study. Sometimes they need that concrete information to give to them because they can't pull that up. They can't pull that experience up. That how can I do, as Dr. Coleman said, the whole household supporting you in doing that. I got that from my family, but not everybody get it. Okay? Thank you.
Whew, whew. All right. I know we are going long. I know we're going long, but this is really, really some good stuff. So I really appreciate you all for hanging in there. We have 2 more questions and we'll finish this up. I love the way it's been a nice flow into things. And so now Ms. Raynetta Stansfield will answer this last question, or not the last, second to last question. How do we stress the need for mentorship in allied health programs to administrations, and how do we educate students on how to assertively seek out mentors, whether an official mentorship program is provided at their institution or not?
All right. Well, first I want to say hello, everybody, and thank you for attending. With me, I believe it's important to have a mentorship, to be a mentor and to be a mentee, because it's important not just for school, but also for employment. The benefits of having a mentor can be knowledge transfer. It can be someone that can relate to you. Just as Reverend Williams said, this person does not have to be an African American. I have had multiple mentors, different races, different sex, and they all serve different purposes that helped me along the way. I've had one that helped me in my bachelor's degree, one that helped me in my master's degree. I'm currently now in school for my doctorate. All of them served a purpose. And so it's important that we seek out, because one thing I notice about African Americans, us, because I'm African American, is that we have this superwoman and superman syndrome where we try to take on everything ourselves. And that is hindering us from becoming a mentor or for being a mentee. And so having a mentor also helps in regards to your mental health. And some of this piggybacks off of what Dr. Coleman was saying, and again, what Dr. Reverend Williams was saying. All of us does not have family support. Some of us have to seek help from friends, from schoolmates, from professors, and I believe it's everyone's responsibility, such as the school administrators, professionals, if you're a worker, also from your school administrators to assist you and to have those resources. I have had friends who have went to college, and what I liked about those schools is that during orientation, those professors were required to be a mentor to someone. And during the orientation, speak and say how it's important to also have that person and to sign a contract saying this is your person who you will contact throughout your program. And I just believe that it's just very imperative to everyone's life. And I just seek and hope that everyone that's here who's speaking will become a mentor, and those who are in school will seek a mentor. And I just wanted to speak on that.
Thank you so much. I really want you all to get what she said. Sometimes you have to go get some things. Everything is not laid out for you. If this is what you really want, you have to aggressively seek it. When we want something in life, we know sometimes we have to do more than what's on the table to get it done. And so she didn't tell this story, but she said that when we were doing our prep meeting, she talked about she sought out a mentor with somebody that, can you tell that story? The person who you sought out in the hospital? I think that's a valuable conversation to have.
So I started where I currently work at now, which I'm not going to mention, but I started 2 years ago there. And as the new manager, I just went and knocked on a young lady's door who I've watched how she moved throughout the hallways, how she communicated with other administrators. And I was like, that's who I want as my mentor. So I just knocked on her door, didn't know her, I just introduced myself. I said, hey, my name is Raynette. I'm the new manager of blah, blah department. And my department is a union department. And I see that your department is a union department. And I just want to know, will you be able to be my mentor? Can I knock on your door anytime I have questions, whether it's about the job or things about my career or things like that? And she was like, absolutely. Thank you for knocking on my door, because people don't ask for anybody to be a mentor. So I welcome that.
Yes.
So
and it's important to know she wasn't in your field, right? She was not in
my field.
Totally different field. But she saw something in her that she wanted. And in order to get something that somebody else has, you have to learn their craft and learn about them. So, and that takes vulnerability, and it takes transparency to say, I need help. And we all
It
need
absolutely does.
them.
And I believe too, it's important too when you're seeking a mentor to seek someone who you believe can match your energy, because that's also important when seeking a mentor, because you will want somebody who can encourage you. If you're a mother, who can encourage you to keep on while you have children. If you're a spouse, someone who can encourage you to keep that marriage alive while also seeking school, or a friend who can encourage you that, hey, I know me and you can't go out as much, but I'm still here for you when you need to. So you have to have somebody who can match your energy to help you along the way.
Absolutely. Absolutely. I think that perfectly then goes into our last question, because it is teaching us as students, we have to be proponents of our own education. We have to do something. And so Professor Campbell's question is this: what can be done to help African-American students understand the importance of removing the sense of entitlement that appears prevalent in modern generations? And how do we express the need to grasp critical thinking skills versus just being given the answer?
Good evening, everyone. I have been tasked with being the devil's advocate to everything we have been discussing this evening. So while our students do face difficulties in their education, there's still the side where they have to be held accountable for their part in gaining their education. So in thinking about this generation has gained itself the title of being the popcorn generation, where they want everything quick. They want everything handed to them. They don't want to put in the work to make things happen. And a lot of the thought could possibly come from the fact that they may have come from impoverished backgrounds. And this doesn't apply to everyone, but some of them may come from impoverished backgrounds where they've watched their parents or caregivers rely on the system to help them meet daily needs. So this kind of instills in them, hey, you get this, you don't have to work to receive this help. And then you have other people who come from backgrounds where their parents seek to not make them go through the life that they did growing up. So they give them things without holding them accountable for getting good grades, cleaning their rooms, just doing things that we would do as children. So they don't process the fact that you have to put forth some effort to gain what you're seeking to do. So in this climate, students are aware, especially in this climate, in the education system, that faculty and teachers are required to do pretty much everything they can to assist them in navigating the times and navigating their education and making sure that their needs are met, or that they are able to basically succeed in school, in hopes to get them to not withdraw. And students they're lazy, so they'll take advantage of that. And because they know they are supported, this kind of creates a lack of accountability in some of them. So they don't feel like they have to show up to class on time. They don't feel like they have to meet the deadlines for assignments. They feel like, if I give my woe is me story, my teacher has to accept it and help me. So I can just take care of this when I take care of it and it'll be done. Well, there are standards for programs, particularly these healthcare programs. And we have accreditation standards. We have standards for the schools. We have even personal standards for why are you even here? Like, working in healthcare, you are ultimately, you have other people's lives in your hands. So like, what is your why for being here? And educators having to kind of bend the rules a little bit, it ties our hands, because students don't put in the maximum effort that they can because they know they don't have to. So in doing this, we basically have to teach students that to whom much is given, much is required. And we can help you to an extent, but we still need you to meet us halfway as well. So in doing that, we can create goals. And I know my partner in the program, she has the students create goals that they want to meet, that they would like to meet each week, and then they address them. And this holds them accountable to stay focused and stay targeted in what they are trying to do. And as far as critical thinking is concerned, using critical thinking skills allows you to take a more in-depth look at what's being addressed or the problem that you're trying to solve. And it causes you to apply reasoning and to make connections between different ideas. So this helps the students to come up with a more personalized thought and conclusion of why they are doing this and what is the purpose behind me being in this program? Like, what is the ultimate goal? How can I make an impact? What is really my purpose for being here? So basically, it's really just encouraging the students to find a sense of empowerment in the effort that they put into what they are trying to obtain. Because even in the healthcare programs, when we send them to clinical sites, we match their classroom effort to how they are likely to treat the clinical site. And the purpose is to get the hands-on part of what we're teaching in the classroom, but it's also to set them up for getting a job when they finish the program. So we can't really pat them on the hand. We can help them, but we can't really just let them be lackadaisical and everything, because we are sending them out into the field and we are allowing them to practice and gain experience on real life people. And I often say to my students, with the effort you're putting into what you're doing, would you want you to operate on your mother or on your father, on your sister, your friend, your husband, your children? So basically what you put in is what you'll get out, and you ultimately have other lives in your hands. So you really need to take a good look at, why am I doing this? How am I impacting others? And what sense, like, how do I feel at the end of the day from doing this?
Yeah. So we have to have a part 2, apparently, because I know we can go on and on with this topic and this conversation, and we have just brushed the surface. And so what I'm going to do is this. We have plenty of questions in the chat, and I'm not going to hold you because I know my students start leaving. So, or they exit the building, even if they start packing up your books. So I know they're packing up books, getting ready to go on us. But here's what we will do. Since we have the website designed already, the questions that are in the chat, I am going to press on my panel members, and we will disseminate those questions and have them answer them, and we will post those on the website for you. But I am definitely open to having a part 2. I think that this was a wonderful conversation. I don't want to hold you all much longer than this. So thank you so much for being a part. I wish I could give my panel some final words, but everybody is leaving out of here. So I'll let them go ahead and go on. Please fill out the survey. And again, if you are a student seeking credit for this, being at this event, please fill out the survey and put your name and your email down there so that I can make sure that your professor gets that information that you were present. Thank you so much for your time and attention and for the extra minutes you gave us. Have a wonderful and blessed evening. And I hope you got something out of it. Take care.